Okay, we're live. So, physiological transition of the newborn. And then what we're really looking for is how does the baby take his first breath? Why does he take his first breath? What's going on inside of his body? Because he has to go from a water breather to an air breather. He has to go from an organism that is not using his lungs at all and getting all of his respiration from somewhere else to an organism that is using his lungs as the primary organ of respiration. Okay, and he has to, his kidneys weren't filtering out impurities. His bottom wasn't making poop. He wasn't breathing. He wasn't making noise. He was just kind of swimming around underwater having a good time, and his mom was doing all the work for him. Now he has to do all the work for himself, and so he has to make some major changes, and they happen almost immediately. Now, I like to think of this as a spectrum, okay? That the babies don't go from fetus to newborn as though something magical happens at birth. There's not a magical gateway that he has to cross through. The transition is actually a lengthy period. It starts very early in gestation. They start to taste at what is it that they start to taste at? Something like 10 weeks gestation. They begin to develop taste buds, and by 30 weeks gestation, they can tell the difference between sweet and sour. And they start to hear at 20 weeks, they can hear mom's voice. At 28 weeks, they can hear dad's voice and the noises around them. They start with building their musculoskeletal system extremely early as 8 weeks on ultrasound. You can see a baby swimming around and doing stuff. Okay, he's not playing; he's exercising. Okay, he's building his nerve endings. What happens is the nerve endings start in here, and every time he does this, they develop outward. Okay, and so when he does this, he's learning how to make the nerves do this. Then he does this, and he's learning how to make the nerves do this. And then he can do this, and he learns how to make the nerves do this. And when he's born, he can do this. After, thousands of hours of practicing, he gets to do this. And sometime by 6 months, he gets to do this, and then he gets to play the piano, okay? And all of that is a transition from when he first started with the herky-jerky movements to the more sweet and swinging motions, and then eventually fine, purposeful motions. And so this transition is not what happens in the first 5 minutes of life. It's what has been happening since he was very early in pregnancy and continues to happen until, he reaches adulthood and he finishes his development. But for the sake of this, we're going to look very, very closely at what happens around the birth itself. Okay? Now, there are several theories to how the lungs change from water-filled to air-filled, and the one that I like is this one here. What happens is, in utero, you have this network of blood vessels surrounding every single capillary, or every single alveoli, right? And there are millions of alveoli in the lungs. And they've got this network of blood vessels around them with very little blood volume in them. Only 8% of the cardiac output goes to the lungs in utero because the baby's not breathing. All the blood that goes to the lungs is there to provide nutrients to the lung tissue so that it can develop. Okay? And what the body does is it creates a little sac, and then it wraps that sac with blood vessels so that it'll develop a bag, and then it fills that bag up with fluid to give it structure. That's how it makes the stomach, that's how it makes the bladder, that's how it makes the lungs. And so it fills them with fluid to make a structure, and then when it develops that structure, and when the baby's born, it empties all the fluid out and leaves the structure behind. Kind of like when we were kids and we made paper mache, and we took a balloon, we blew it up, and we covered it with paper mache, and then we popped the balloon, and we had a little bag, a little solid structure. That's how the body makes bladders and lungs and hearts and stomachs, is doing that, okay? So that's what's happening here. Now, at birth, what happens is the baby takes a breath, and instantly the vascular resistance in the lungs drops dramatically, and 40% of the cardiac output goes to the lungs. And so what happens when you get this massive shift from very little circulation to a lot of circulation is each capillary fills up with blood, and it becomes what's called erect. Okay? They all of a sudden get very large and distended and erect. Okay? And so what was this collapsed network with this little itty bitty thing all of a sudden like that, it fills up, okay? And so it creates this erect structure with lots of little bitty balls all over the lungs, and those are the alveoli. Now, because amniotic fluid is a fluid, it's going to respond to osmosis. So when all of a sudden you got this hyperosmolar blood, creates a network around the capillary, it sucks the fluid out of the capillary through osmosis. It pulls it into the vasculature, and all the lung fluid gets pulled into the vasculature very, very quickly. Okay? And when that happens, each alveoli is now empty. Okay? But it doesn't go in, it's not just empty, it creates a little negative pressure. Okay? Because all of a sudden all the fluid is pulled out of there, we've got negative pressure in each capillary all the way through the lungs. And it gradually builds and builds and builds in pressure until the baby goes and pops that valve. Okay? Because he has so much negative pressure built up in his lungs that it overcomes the pressure outside, he goes and he takes a breath. Watch a newborn take their first breath. It is a wonderful thing to see. The baby comes out, he's like this. Just like that. And it takes about 30 seconds for the average newborn to take their first breath. That's the average, 30 seconds, okay? They are not meant to come out screaming. They're not. They're meant to come out and go, hold on a minute. Got it, okay, I understand now, okay? Because all of those alveoli have to clear, okay? And it takes a little bit, just a second or two, but it takes a little bit for all those alveoli to clear of lung fluid, okay? So that's called the capillary erection theory. It was written by George Vyas, a wonderful guy back in the 60s who worked all this out using cadaver lungs, fetal cadaver lungs. Now, another way that your book talks about is increasing pressure from above. That what happens is as the baby is born, they squeeze all the fluid out of the lungs. And if you ever watch a baby be born, pay very close attention to his face, and you'll see when his head pops out, fluid comes flying out of his mouth. Okay, it's pretty impressive when you see it. It looks like he vomited. It's because it squeezes all that pressure out of his lungs and it pushes out. Okay, but babies born by C-section who don't get the squeeze, they still learn how to breathe. Okay, and then some people say that when babies learn how to breathe because they get the shock from 98 degrees to 70 degrees in the room, and that sudden hot to cold causes them to like that and take a breath. Okay, very common theory, and there's some truth to it, but babies born on the equator, or babies born above 100 degrees outside, they still breathe, even though it's warmer on the outside than it was on the inside. Okay, so there are several competing theories, and the answer is yes, all of them are right. Okay, that yes, the capillary erection theory is right, the intrapulmonary pressure theory is correct, the hot to cold theory is correct, the squeeze, all of them are right. Okay? It's a mutually redundant system, and the body uses whatever it needs to make it happen. It does all of them at the same time.
So you're talking about the chemical, sensory, environmental
that's another
factors,
one.
right?
So there's so one thing that we know is that as it is the rising intrapulmonary or rising what's the word I'm looking for? Oxygen concentration in the blood that triggers the body to make that change. Right. From fetal to neonatal. So what happens is as the baby's partial percentage of oxygen rises, that's what makes the shift from 8% cardiac output to 40% cardiac output.
You're talking about the bioreceptors, right? Yeah.
So there's a chemical piece to it, and it's the chemical piece underlies all of this. Okay, that's the trigger that makes the body change from 8% cardiac output to 40% cardiac output, is that rise in partial pressure of oxygen. Fly is driving me crazy. I swear I brought him in, he's with me. Did I tell you guys I found a wasp nest in my backyard the week before last?
Oh.
I did. I found it with my weed whacker. That was not pleasant.
Stung 47
I got stung
times.
just 11.
11. Oh. I thought it was more than 11.
They still itch. I'm still like, it's been like 2 weeks. Anyway, another thing that happens is surfactant. And surfactant is important because surfactant only comes at term. So preterm babies have very little surfactant, and they have trouble breathing. So we give them a drug called Surfacta, and it allows them to breathe. We just put surfactant in their lungs for them. But surfactant decreases the surface tension and allows the fluid to pull away and go into the vasculature. Okay. So here's a nice diagram, this is what you were talking about the chemical factors, okay? So we've got several changes going on. We've got the internal stimuli as his oxygen level increases. We've got the external stimuli, which is the heat, the squeeze, and all that other stuff. And they all work together to support what we were talking about. So you stimulate the respiratory system, you stimulate them, and you get them moving around and breathing, then he starts to breathe more. The lungs, as he's being born, get compressed and draws air into the lungs. Okay. The message is sent to the respiratory center, activates the chemoreceptors, drops the PO2, rises the PCO2, drops the pH, and causes chemical signals that makes the baby breathe. Okay. Now, understand that in utero, a baby does not have his entire circulatory system inside his body. Okay? Where is a major organ that sits outside the body that you only have when you're a baby in the uterus? The placenta. Okay? Your placenta. And in preterm babies, it holds 50% of their blood volume. In term babies, it holds 30% of their blood volume. But it always holds a lot of their blood volume. Okay? Because that is the organ of respiration. That's the organ of elimination. That's the organ of nutrition. It's all being done by the placenta, not being done by the baby. Okay? And then when the baby is born, all of a sudden now he has to breathe on his own. His kidneys have to start working. He has to start processing things that he didn't have to process before. Now, if you guys were all making chocolates at a chocolate factory, and I all of a sudden doubled your quota of chocolates and cut your hours, what would happen to you? You would complain, right? All of a sudden you're working too hard, you don't have the resources you need, okay? When you deliver a baby and you leave 1/3 of his blood volume behind in the organ of respiration, you have just increased his workload by putting him on the outside, but you've taken away 30% of his resources. Guess what babies do? They complain about it. They get very pale in the face, very blue in the hands. They sleep like crazy because they don't have enough blood volume. If I took away 1/3 of your blood volume, you would be pale in the face with red eyes, blue hands, and you'd sleep all day long because you didn't have the energy to get anything accomplished. Okay? So understand that when the baby is born and he gets that transfusion of oxygenated red blood from the placenta, his internal circulatory system volume is going to increase dramatically. It's going to increase by 30%. And he needs that circulating system to increase by 30% because all of a sudden he has to feed the lungs, which he wasn't using before. Okay? So he needs that when he changes from fetal to neonatal circulation. Now, when a baby is born, some of the very first things you have to look at is he breathing and is he pink? Okay? Your baby should always be able to oxygenate himself very, very well. You guys have heard about acrocyanosis, that a baby's hands and feet are blue. They're not normally blue. We make them blue because the baby's hypoxic, because we left 30% of his oxygen carrying capacity inside. Okay? So a big thing that contributes to acrocyanosis is the fact that he's hypovolemic. He doesn't have the blood volume it needs to circulate his hands and feet. You'll hear nurses, and I love to hear this, and I learned this when I was coming up too, and I still hear it. People say, well, the baby's hands and feet are blue because he doesn't have the power to get the blood from his heart to his hands and feet. Have you guys heard that? That there's not enough cardiac power to get the blood out there? It's almost normal. Okay? It's extremely common. I still have my doubts about whether or not it's normal. It's not harmful, but it's not necessarily normal either. Because what happens is, when you have a baby who gets delayed cord clamping and they get all their blood into their body, you'll find his hands and feet are not blue. Okay? They're certainly not, they're very, very close to his skin color. There is a degree of peripheral vasodilation that happens just to maintain temperature. So as babies get a little cold, their hands and feet turn pale because their body shunts all the blood away from out here because there's a lot of temperature loss out here and puts it in the core to warm up his organs. But that's very, very little, and it means your baby's cold. Again, not normal. That means there's something going on. You got to cover that baby up. Okay. So but a baby at birth should be nice and pink all over, and he should be breathing and have a nice, steady respiratory rate. This is another. This is fetal circulation. The transition from fetal to umbilical, or from fetal to neonatal blood volume. And so you're going to see, this is a little bit of a busy slide, and I'm sorry. Okay. So what's going to happen is as the oxygen levels rise, you're going to get a drop in pulmonary vascular resistance, which means all of a sudden the lungs will open and blood will pour into the lungs because you've dropped your pulmonary vascular resistance, which is going to increase your blood flow, increase your left atrial pressure because the lungs are all of a sudden, the blood is flowing to the heart, like flowing into the lungs and the heart like crazy, and it's going to close that foramen ovale, okay, that hole in the heart between the right and left atrium, okay. You're also going to get an increasing systemic vascular resistance. So as the lungs open, all the peripheral vessels tighten, okay? And so you get an increase in pressure here. So you've got this opening, decrease in pressure here, so blood is flowing in, and a tightening out here, which is causing a backup this way. So what you've got is you've got a load going on the heart coming into the heart, and a load pressing up coming out of the heart. So it causes this massive pressure increase inside the heart and the lungs, okay? And when that happens, that massive pressure increase, just like a massive pressure increase would blow that door closed, closes the foramen ovale, the ductus arteriosus, and the ductus venosus. Okay, does that make sense? So the increasing vascular resistance decreases the venal cable return, which causes a decrease in blood flow through the umbilical vein and closes the ductus venosus. And increasing pressure in the aorta, which closes the ductus arteriosus. Let me show you that in a picture form. Okay. So on this side, we have our fetal circulation, and on this side, we have our newborn circulation. Okay. Same baby, so all the pictures are the same, but notice the color changes here. See the blue vessels coming up, and all of a sudden they turn red, right? Okay? And then notice in the aortic arch how it starts off red and then it goes to blue. Okay? Now look here, and you'll see that the ductus venosus closes, and that your aorta, the ductus arteriosus closes, and everything shuts down, and it becomes, you don't get this blend from oxygenated to deoxygenated. You get it all, it's all one or the other, right? And this is, now we've got our adult circulation. Because what's happening, I wish I had something long to point with, and I don't. What's that? Mr. Bones' arm. I think I can use this. No? Not turned on. Okay. I need the laser pointer. I have insurance. What do I care? So what happens is, you've got this massive decrease in systemic pressure in here. Okay, so blood is flowing into here. And you got this massive increase in pressure out of the aorta and in all the peripheral blood vasculature. Okay, so you've got this force pushing blood toward the heart and allowing blood to flow into the heart and lungs without resistance. And so it's that massive shift that closes your foramen ovale, closes your ductus arteriosus, and closes your ductus venosus. Make sense? I'm not blowing your mind, am I? No. Okay, good. Fascinating how it works. What's even more fascinating is how little we understand. Every single person on the planet has to be born, and we don't really know how it happens. It's amazing to read the literature about why babies take a breath. And they're like, I don't know. I haven't the foggiest idea. There are literally 7 theories for why babies take a breath, and we don't know which one is right. I like the capillary erection theory myself, but there's frog breathing, we already talked about it. It's a lot. So as soon as baby is born, you're going to notice a massive change. And so within 30 minutes, his pulse should be nice and stable between the 120s and the 160s, just like it was before. He should have nice, good capillary refill, less than 3 seconds, just like grown-ups do. And a capillary refill of greater than 3 seconds means we got problems, right? Or greater than 4 seconds means we got problems. Okay? They very, very quickly turn into grown-ups. Okay? Now, temperature is very, very important for babies, because if they get cold, they burn up blood sugar, okay? And they very quickly lose fat. Anybody reading the book about brown fat?
Yep, that's what they use to keep them.
Yeah, what is brown fat?
That's what they use
Very
to
fast.
regulate their
Okay, Vascular,
Very
exactly.
vascular.
Very vascular fat. Because normal fat, my fat is not vascular. If you cut me open, my fat would be white. But a baby's fat is brown because it's incredibly vascular. What happens is blood flows through the vascular brown fat and it gets warmed up in the fat. And then it takes that temperature like a little charcoal briquette wherever it needs it in the body. Okay? But if he's using all of his brown fat, guess what? He burns it away. It increases his metabolic rate. And if you increase a baby's metabolic rate, then you burn off their blood sugar. Okay? And a baby with no blood sugar is in deep trouble because what is the most sensitive organ on the human body? The brain. Incredibly sensitive to glucose. If you deprive it of glucose, your brain suffers. And babies have a decreased ability to tolerate that. They can't, like if our blood sugar drops, we just go, oh, I don't feel good. And we sit down and our body kicks in. Babies don't have that ability. So it can cause brain damage if you let a baby's blood sugar get too low. Okay? So we have to maintain a neutral thermal environment for the babies. We always want to make sure we keep them warm. Understanding that these little suckers who are incredibly sensitive to temperature have an awful lot of problems with maintaining their temperature. They have a large body surface area, okay? And they lose weight, they lose heat really fast. They don't have very much subcutaneous fat on the skin, especially preterm babies. Preterm babies are almost no fat, okay? A term baby, your baby builds fat in the last month or two of fetal development. They're early on, they don't have a lot of fat. All their stuff is going to development, but once their major organ systems get developed and start to function well, then it changes to fat production because, of course, that's what's extra, right? So preterm babies have very, very little body fat. They look like these skinny little monkeys, the poor little guys. They always remind me of those capuchin monkeys, those teeny tiny little monkeys. Are all hairy. That's what 24, 28 weekers look like. They look like little capuchin monkeys, the poor little things. They're so cute. I remember the first time I saw one, his name was Marco. And I was like, oh my God, what's wrong with Marco? He's a little monkey. And my wife, because she was a NICU nurse and I was a cook, she was like, oh, that's cute. He's not a monkey. That's just what 28 weekers look like. But anyway, they have very little subcutaneous fat, and they don't have the ability to shiver. Why don't they have the ability to shiver? Because they're still working on this, right? They can't get this down yet. So they don't have the nervous system development that enables them to shiver, okay? The closest they can get are those tremors, and they're like this, which is close, but you don't want to see that in a baby. That means he's got some problems, okay? And then they have very thin blood vessels, and they're very skin thin, and their blood vessels are very close to the surface. So they're blowing off heat through those blood vessels, the circulatory system, so close to the surface, okay? So in order to adapt to this, they increase their metabolic rate and their muscle activity, and that burns off an awful lot of calories. The other thing that they do is they have peripheral vasoconstriction. Like I said, this is where a lot of that acrocyanosis comes from, is that they tighten up their blood vessels here and push blood into the chest to keep their core warm, because it's easy to warm this part and very hard to warm this part. The other thing that they do is they pull up close to their body and make themselves a tight little ball, okay? And then finally, the non-shivering thermogenesis. Fancy word, but that's that brown fat I was talking about, is they metabolize their brown fat. They only have a little brown fat, and it goes away quickly, so don't make them lose all their brown fat, okay? You'll notice that all newborns lose weight in the first 72 hours. Hello, that was their brown fat. They lose it, okay? Because we burn it up, just because it's part of the process of being born. So even a healthy newborn is going to lose 3 or 4% of their birth weight. An unhealthy newborn can lose 5 to 10% of their birth weight, and that's a bad thing. So this is very, very, very important. Like I promise, you're going to get a question on a test sometime in the future that suggests, what kind of heat loss are we fighting against? Okay? This is important. Okay? So there are 4 main types of heat loss: evaporation, conduction, convection, and radiation. Evaporation is just what it sounds like. Moisture on the skin, the air blows across it, it evaporates, it makes you cold. It's the same thing as you sweating, right? But if you've ever seen a newborn, are they born dry? No, they're born dripping wet, covered in their mother's blood, right? Okay? That's a lot of evaporation that happens if you don't get that off of them. So immediately at birth, we have to dry the newborn very quickly, get in all his creases, and get him as dry as we can. Because anything that's wet, especially on his head, is going to evaporate and make him very cold very quickly. Okay? The other is conduction. Conduction is heat lost to a cold object. So if I put a baby on this table, it's cold. You put your hands on the table, you can feel that it's cold, okay? But if you notice, you put your hands on your table and leave it there for a minute, it starts to warm up, right? Where does the temperature come from that makes the desk warm up? Your hand. So your hands are losing temperature to the table. That's conduction. And if you take your hands after they've been on the desk for a while and put them on your face, they're cold, okay? That's exactly what happens to a newborn. All of a sudden, whatever he was touching that was cold takes all of his heat away. So if you take a newborn and you put him right up on a cold warmer that hasn't been turned on, or you put him on a cold scale where they're going to weigh him, guess who gets cold? Okay, all of a sudden you're laying down on a block of ice, you're not going to feel good. And it's going to take all your temperature away. That's conduction, from a hot source to a cold source. So you'll notice that when the babies are about to be born, they turn the warmers on, they get everything all pre-warmed and ready for baby to be born. And then there's convection. Heat lost from cold air blowing across the skin. Okay? This is not evaporation, but it's very similar to it. Evaporation is the actual evaporation of moisture from the skin. But even dry skin, if it blows, will get cold. That's how fans work. That you're hot, you turn on a fan, or you do this. That's convection. I'm blowing cold air against my body to take the heat away from me. Okay? That's how convection ovens work too, by the way, except they're heaters instead of coolers. Okay? But that's convection. And then finally is radiation, and that's the heat lost to the colder environment. Which is why a room, if you're in a small room with 10 people, all of a sudden it gets really hot because your body radiates heat and it doesn't have anywhere to go. Okay? So a baby who's left uncovered will radiate heat into the cold environment and lose his temperature. And I have a picture of the 4 different types. So A is what kind of heat loss? Not evaporation. It's convection. Well, actually, because it says dry air, it's probably assuming that the baby is wet. It should say a wet baby or something. You're right, that is evaporation. This is convection, right? Dry air, air blowing across and taking the heat away.
Yes.
And how about this?
Radiation.
Radiation, exactly. His heat is leaving his body and going into the environment. Okay? And the one on the top? Conduction. Yep. So it's evaporation, conduction, convection, and radiation. Okay? Now, let's talk about newborn blood volumes. So, we talked a lot about how the baby's blood volume is going to be. It reaches 100% when you allow delayed cord clamping. People talk about he'll get too much blood. He can't have too much blood. It's his. It was his to come. It was what he was given. You guys can't have too much blood either unless there's something wrong with you. Okay? You only have your own circulatory system. But they always forgot when they talked about, you know, the placenta has all this extra blood. They forgot that the lungs aren't taking any blood. Okay? Before birth, now remember, if there's 30% blood in the placenta, right, at term, and 8% of the baby's circulatory system goes to his lungs before birth, and 40% goes to his lungs after birth, what's 40 minus 8? 32%. How much blood is in the placenta? 30%. Okay? So where is all that blood going to come from? It's going to come from the placenta. That is the primary reservoir of his own circulatory system after it loosens up in there. Okay? So his blood volume will stay stable if you allow him to take his blood. Which is why, by the way, preterm newborns suffer problems with anemia and brain bleeds and gut bleeds, is because they've left half of their blood behind. The first thing you have to do with a pretermer as soon as you get him to the NICU is give him a blood transfusion. Yeah, because he lost half his circulatory volume when you delivered him and didn't let the blood come. Okay? We now know that that's a dangerous thing. I still can't get obstetricians to do it, but if they would just delay on their pretermers 45 seconds, they would have a far shorter neonatal stay in the NICU. They won't do it. They're still boneheads. Now, like, because it said new evidence. It came from the 80s. It's not there yet. But the cells in the blood themselves have to change too. Remember, newborns have babies in the womb have a fancy kind of hemoglobin. What's it called? The hemoglobin you might find in a fetus is fetal hemoglobin. Okay, and fetal. I know, it's like it's there. It's so obvious. What is it? It's fetal hemoglobin. And fetal hemoglobin has a higher affinity to oxygen, which is why mom's pulse ox in labor is 100% and baby has a D cell and we give her oxygen. Because we're not giving oxygen to her, we're giving oxygen to her baby. When we oversaturate her hemoglobin, the baby takes it from her very readily. Okay, so so baby's fetal hemoglobin has such a high affinity, binding capacity to oxygen that it doesn't even need to be saturated. The average fetal pulse ox is between 55 and 65. What would you guys look like if your pulse ox was 65? You'd be in bad way, right? Yeah. Because your oxygen carrying capacity is so limited, you have to use 100% of your hemoglobin in order to walk around. Okay? Babies don't. Babies only need 55 to 65% of their hemoglobin being used in order to breathe. How cool is that? Okay? But as soon as they're born and they get this massive change, they lose their fetal hemoglobin. And within the first couple days of life, they change to adult hemoglobin. And so if you test a newborn at like a month old, you'll find his fetal hemoglobin count is very, very low. And his adult hemoglobin count is up in the 90s, just like yours is. But they very quickly change it. Okay? And that's important to understand because the body doesn't just throw things away. What do you think the body does to the fetal hemoglobin? It has to turn it into, right? It has to break it down and rebuild it. And that breaking down causes what? Bilirubin to go up. Because you've got waste products from that fetal hemoglobin. So that's where that's coming from. Okay?
But isn't that why they also worry about pushing the blood into the fetus or into the newborn too, because of the bilirubin?
We do know that babies who have delayed cord clamping do have a higher bilirubin level.
Yes.
They don't have a higher incidence of jaundice. They just have a higher bilirubin level. So their bilirubin level rises, but not to the point of pathology.
Okay.
Okay? And that's what freaks people out, because they're like, oh, the bilirubin level's going up.
Right.
But it's still normal. Which tells you that the actual bilirubin levels are wrong. Because we're using a non-physiologic measure to judge what our bilirubin levels should be. We're really supposed to be using a physiologic measures. So we want to know what a normal baby does, and then say what's normal and abnormal. We don't want to take a baby who's lost 30% of his blood volume and use him as our study sample. And that's what they did.
Isn't that the argument that that's normal?
What's that?
Isn't that the argument that that's normal?
What, to lose 30%? That is the argument. And it's not normal. Because all that's normal is what you're born with. This is what's normal. Anything you do to me or for me is an intervention that changes me from normal. Right? Circumcision, common, not normal. Right? Immediate cord clamping, common, not normal. Nipple pain, common, not normal. Again, anyway. So, well, you're going to hear that a lot, right? Yeah. So, hepatic active, he has some glycogen, but he's going to burn it up very, very quickly to maintain his blood glucose. It's a very limited ability to control himself. And babies, that's why newborns have such a low, such a sensitivity to blood sugar problems, because they have very limited glycogen stores where we have plenty. Okay. He also has limited iron storage. It's very, very common for newborns to get anemia right around 3 or 4 months. Infantile anemia, incredibly common. And we're not exactly sure where that comes from. We know that delayed cord clamping makes that level go down, but we still know that there's a lot of anemia. And we think that's part of the transition to from fetal hemoglobin to neonatal hemoglobin. When you read about pretermers, they're particularly sensitive to it, that their erythropoietin isn't working as well, and they become anemic very easy. And then there's conjugation of bilirubin, which is what the liver really is good at. Okay? We're going to talk about bilirubin a little bit later, though. So, you might notice, if you're using the slides, that these slides are going to get just a little out of order. Don't worry, I didn't take any away. I actually left them here in this presentation. I just moved things that I thought were important up front, just in case we run out of time. Okay? So I talk about all the bilirubin at one time, and then you'll see it in your things later on. Okay? So, so there are several types of jaundice. Okay? First is a physiologic jaundice, the normal jaundice. Anywhere, 50% of newborns and 80% of preterm babies will develop yellow skin in the first 48 to 72 hours of life, okay? Just a little yellow. If you dress them in orange or something, they'll look bright yellow, okay? I always tell my parents, never, never, never dress your baby in yellow, because it just makes them look sick, okay? It makes the pediatrician draw blood even though they're normal, because they just glow yellow, okay? And a little yellow is okay. They start moving toward carrot orange, and we got problems, okay? So babies get a little physiologic jaundice. One of the theories out there is that physiologic jaundice is a marker of, what's that word? Free radical production in the body, and that the body is using those free radicals to break down things. So there's definitely a physiologic component, and we believe there's a healthy physiologic component to that little bit of yellowness in the first couple of days of life. That's physiologic, that's normal. It's going to rise a little over the first 48 hours and then quickly start to go away. There's pathologic jaundice. You know your baby is pathologically jaundiced when he is yellow in the first 24 hours. A baby whose bilirubin jumps so quickly that he turns yellow in the first 24 hours, he's got problems, okay? And so when he gets jaundice in the first in the first 24 hours, that really makes a pediatrician nervous. A little yellow the second 24, not so much. And then your book talks about this thing called breastfeeding jaundice. Breastfeeding jaundice is a myth. It does not exist. Okay? It's actually breast not feeding jaundice. Okay? It's a baby who is supposed to be breastfeeding, but he's not actually eating. Okay? And so it's the same thing. They say, well, it's breastfeeding jaundice. It means breastfed babies, they get such low volume that they get jaundice because they get a little starvation. Okay. No. Breastfeeding babies who are eating well do not get low volume. They get exactly what they need. It's the breastfeeding babies who aren't eating well, who look like they're eating well and they're not, because they're pinching mom's nipples, they're interfering with blood with the milk flow, or they've got a bad latch, or they've got a tongue tie, or something is wrong and they're not able to get milk out. Those babies are not eating, and that's why they turn yellow. It's not really breastfeeding jaundice, it's breast not feeding jaundice. But again, the American medical system is so ignorant about breastfeeding that they have no idea what they're talking about. And so they look at a baby on the breast and they go, great, he's eating, isn't that wonderful? No, a baby at the breast is just at the breast. I don't know if he's transferring breast milk or not. Okay, I know he's supposed to be eating, but I don't know if he is. If I give my kid food and he messes it around a little bit and when I'm not looking, he passes it off and gives it to the dog, he didn't eat it, I didn't notice, I assume he ate, right? But I wasn't assessing properly. And the same thing happens when pediatricians look at breastfeeding babies. They assume that they're eating, and they're still turning yellow even though they're eating, and so they blame it on breast milk. They're not eating, and that's the problem, okay? Those are babies who are not feeding well, and they get jaundice. It's a marker. It's kind of a little bit of starvation. If you don't eat, if a newborn doesn't eat for 24 or 48 hours, they get very, very yellow, okay? And then there's breast milk jaundice. Breast milk jaundice does exist. We don't know what it is. It's some enzyme in breast milk, but it turns babies a little yellow, but it's late onset, okay? It's a week, 2 weeks, a month down the road, all of a sudden they get a little bit yellow. That's breast milk jaundice, which is not the same as breastfeeding jaundice, which doesn't even exist. It's actually breast not feeding jaundice, okay? So the way you tell them apart is if it's a feeding problem, it's their jaundice in the first 2 to 4 days. They get yellow very quickly. Not so quickly that they're pathologic, but they get yellow pretty quick. If it's a late onset yellowness, it's breast milk jaundice. 99.9% of the time, it's no big deal. Okay? So there's 3 types of jaundice, or 4 types. There's the normal jaundice that's physiologic. There's the really, really bad jaundice that's pathologic, and it's immediate onset, first 24 hours. Then there's the starvation jaundice, which happens in the first couple days of life, 2, 3, 4 days of life. And then there's the breast milk jaundice, which is late onset and it doesn't mean anything. Okay? Is that clear? All right. Well, I'll explain why this happens in a little bit. So, this is this is the jaundice pathway. Okay, where it comes from and how it happens. All right. So you start with the neonatal bilirubin increasing because of that red blood cell destruction, your hemoglobin destruction. You've got your liver is not quite ready to take care of it yet, and the intestinal flora is not working very well. Okay, so the newborn has some hits against him. Okay, where his body is not quite perfect yet. It's okay. He's got defenses against it. No big deal. All right. So he gets this red blood cell destruction. He gets this increasing unconjugated bilirubin is released from the destruction, and that goes to the liver for processing. The liver does its best, and what it can't process, it sends to the bowel, the kidneys, and to the skin. Okay, in unconjugated form, or I'm sorry, in conjugated form. Okay. Now, if a baby can't eat, he can't poop. All right. Newborns have this reflex called the gastrocolic reflex. It says what goes in must come out. It's the same thing. You wake up in the morning, you have a big old cup of coffee, and you have to take a dump. Same thing, okay? It's the gastrocolic reflex. And so what happens with a newborn is every time they eat, they poop. Which is why if you ever see a baby eat while they're at the breast or while they're having a bottle, they'll fill their diaper, right? It's the gastrocolic reflex. It's as though the system is 100% full. And if I put anything here, I have to push it out here. That's just how it works. Okay? So, a baby who's going to the breast and not eating, guess what he's not experiencing? The gastrocolic reflex. So he's not emptying his bowels. He's not moving his bowels. So as the bilirubin enters his bowels, it's not being expressed. It gets pushed back to the liver and to the skin. Okay? So that's where the not feeding jaundice comes in, because they're not eating, so they're not pooping, and if they're not pooping, they're not wasting their bilirubin. It has to get recirculated, and it goes to the next way out, which is the skin. Okay. But that's the basics, and some is lost in the urine, which again, if they're not getting a lot of volume, they're not peeing either. Okay, so newborns, it's very important to make sure that they're peeing and pooping. That's why they're always asking you, how often is your baby peeing and pooping? Because he's got to get rid of the waste products. If he doesn't get rid of the waste products, they go right back into the body and they start to accumulate and they become toxic. Your body does it all by itself. They need a little help sometimes. Okay? Don't you love it when you're like, that's why they ask me all those stupid questions. Now I get it, right? So your job as the nurse is to maintain temperature and make sure you prevent cold stress, monitor his peeing and pooping, and make sure that he eats early, eats often, eats correctly. Sound familiar? Okay. Newborn care is so easy. So a little bit more about jaundice. Let's see here. Okay, so this is the slide I took from later on. Okay, it talks. This is it's in the preterm section, but it works really well for terms or preterms. Okay. So it's important to understand. There's the physiologic jaundice, which is the liver, the immature liver, not conjugating bilirubin, using alternative sources that are not being processed properly. Okay, they get the visible yellowness in their skin, usually, and you'll see, and this is pretty nice. 5 milligrams per deciliter in the first 24 hours of birth. They actually quantify it for you. So if their jaundice level goes up very quickly in the first 24 hours, that's your pathologic jaundice. Okay? And you make the diagnosis by getting a serum bili level and seeing how it rises. Okay? Now, this is a way to put this graphically. It's in the back when it's talking about pretermers. Don't worry about it. So this is the bilirubin graph. Okay, notice how it rises. See how it rises very quickly? So we started off down here nice and low. We've got normal, a little risk, high risk, and wow, he's in trouble. Okay, we want to keep it down here in the green zone all the time. So at 24 hours when it crosses 5, he goes into the risk zone. Not ridiculous, but he goes into the risk zone. But look at this, at 48 hours, he can go all the way up to 9. Before we even think about it. And at 72 hours, he can go all the way up to 12, or 11, is it 12? Looks like 12. Maybe it's 11 before we worry about it. So you see, as he gets older, the bilirubin can rise, and it means absolutely nothing. And all we want to do is we want to keep him in the green zone. If he's in the yellow zone, we want to watch him a little bit, but we're not too terribly worried about him. He crosses over into the red zone, then we need to treat his jaundice. Okay? When we do it with ultraviolet lights. Why would we use ultraviolet lights?
The vitamin D.
Remember how I kept saying over and over again that the body pushes it to the skin? Okay? When ultraviolet light hits the skin, it takes your bilirubin out of your skin. It breaks down the bilirubin in your skin with ultraviolet light. So you can just put them in the sunlight and it'll have the same effect. All of my children have a little bit of jaundice. Not bad, but more than they should, every single one of them. So we always have a crib right up against the window with the window open so they get nice and really get sunlight. Okay. With baby number 1, my wife's a NICU nurse. I was a nursing student. We were all freaked out. We actually hung ultraviolet lights on his crib, and like I said, we have pictures with him baking in the lights at home just because we wanted to keep his bilirubin level low. We didn't need to do it. We figured it out. And David, you know, babies 2 through 8, we was like, whatever, you'll be fine. Okay.
Don't they also do with vitamin K though too?
Well, all babies get vitamin K at birth, but I don't think they get more vitamin K. Okay. So what we're going to do, we're going to treat our jaundice first by preventing it. Okay. We're going to prevent it by feeding early, feeding often, feeding correctly. And then when they get into the high risk, we're going to watch them very closely and put them under phototherapy. If you ever go to a nursery and you see the bright blue lights and the baby's wearing blindfolds, that's phototherapy. To bake them in ultraviolet light and kick off some of that bilirubin. Okay? It's especially common in the NICU. But you got to cover their eyes because you want to protect their eyes from the ultraviolet light. You don't want to burn their eyes. And you got to cover the genitals so that you're not going to mess with their testicles. Okay? The ovaries are okay. It's the testicles that we worry about. Okay? And we have to hydrate them. Okay? They need an IV to rehydrate them because we're cooking them off. You know, they're under a lot of pressure under those ultraviolet lights, and they're using fluids, so they have to be rehydrated. Okay? Okay, we talked about this already. That intestinal peristalsis and meconium, that's that gastrocolic reflex. By the way, what is meconium?
Poop.
Poop. And it's not normal poop, is it? It's old poop. It's poop that's been in there since egg met sperm. Okay? It looks like a shrimp, you know, that big black rectum that you have to pull off before you eat shrimp. I don't know how you people eat it. Ugh, I couldn't eat, you know, shrimp guts. Ugh. Anyway, so.
Does it smell like poop?
No. It does. I've never noticed any smell at all. It's just tarry. You know, it gets everywhere. It's such a mess. But it's thick, black, tarry stool. And it's because it's so old. It's 9 months old. It's been hanging out for a long time. And it's super concentrated. Everything he's ever wanted to poop is sitting there in his colon waiting when he's born. Okay? And that's called meconium. And it very quickly in the first week of life changes from black and tarry to kind of green to kind of yellow. And eventually it'll become kind of like a mustard. A yellow mustard with seeds in it. Yep. Isn't that nice? So, he's always been peeing, right? Because that's how the body builds a bladder, as the kidneys have to learn how to work. But in utero, he wasn't using his kidneys to process his urea, which is why amniotic fluid doesn't smell like urine. It's baby urine, sure, but it's not. It doesn't have any urea in it because his kidneys weren't functioning as a filter in utero. Very, very little filtering was going on, just enough to practice. But at birth, he switches over. He loses the placental waste processing treatment plant, and he has to start using his own. Okay, so his urine volume is going to increase very quickly in the first few days of life. And as a general rule, we usually say a baby should pee once in the first day of life, and then once for every day old he is for the first 6 days. So once the first day, 2 the second day, 3 times the third day, up to 6 times on the 6th day. And then they usually will stabilize at about 6 times a day for the rest of their life. Okay? And it's important as nurses to assess the urine. Okay? Not looking at the urine itself, but just making sure the baby's peeing. How many wet diapers are you changing every day? That kind of stuff. Okay? Now, this is where I separate just philosophically away from them. Okay, Babies do not have an immature immune system at birth. They have an incomplete immune system at birth. Okay? Their immune system is not meant to be on its own. They must have their mother to survive. And without their mother to survive, they're going to suffer, right? And so babies have to stay close to mom and get mom's immune system transferred to them through mom's breast milk and through mom's skin. So they're not immature, they're not weak, they're incomplete. And because they're a symbiotic being with the mother, they have to take their mother's immune system in order to be healthy. Okay? And so that maternal microbiome paper that I gave you guys to read all that time ago, that explains it pretty darn well. But everyone likes to think of like babies. I always joke that babies aren't meant to be born and go to college. All right? They got to grow up first. So they have to start very close to mom, right here. And they stay here all the time. And then over the first 4 or 6 months, they start to move away from mom just a little bit. And then 2 to 3 years old, they can be way away from mom and be okay. But they always have to be able to get to her. And then as they get older, they start to move away. And eventually they go to college and hopefully never come back. Okay? That's normal progression. They're not meant to be born and immediately be on their own. They're not supposed to be independent. They're not supposed to be alone, ever. They're supposed to be very, very close to their mother for the first few weeks of life or months of life. Okay? And then we talked about how babies sleep when we did our breastfeeding thing. How they go from deep sleep to crying and alert, and how there's those 6 phases, right? It's just very common sense. They go from dead asleep and they couldn't do anything if you wanted them to quiet and sleeping. So they're alert, but they're not awake yet, to quiet and alert, to fussy and alert, to freaking out, to crying. Okay? And so just understand that. And understand that while all babies tend to be pretty alert in the first 4 hours of life, they then tend to sleep for most of the next 24 hours. Okay. Do we need 5 minutes, or can we push on for 45 more minutes?
5 minutes.
Okay, take 5 minutes. Take 5, everyone, take 5. What's that?
Excuse me. Professor Johnson, I have a question. On our clinical, 28th is a Wednesday, right?
I don't know what Wednesday is, but if it's Wednesday with me.
Right. And then, so the date is just wrong on
Yeah.
here?
Use of non-pharmacological pain options.
Yeah, the 28th happens to be a Wednesday.
Right, and so the 29th is also
We're all just the message.
but that's the wrong
Let me
date.
know if you guys go.
That's Wednesday.
Yeah, it should be the 30th.
Okay.
Well, when it's a Thursday date, if you're going to take here, it's always
Yeah, there's nobody at Cape Fear on Thursday.
Yeah.
Okay.
So it's like for us, it's always like the week of the 29th for
Yeah,
us.
it's just this one, there's a 28th and a 29th. So, and what her problem was is she was saying that if she put all the dates in there correctly, it would be like a 3-page spreadsheet.
Okay, I
So
understand.
just understand that you're either in clinical Wednesday, Thursday, or Friday,
Right.
but you're only in the hospital on Wednesday or Friday, and you're only at PAC on Thursday.
Got
But
it.
she does.
Wait, no.
There's a health department is on
Health
Thursday.
department.
Never mind, I'm gonna get confused. Right?
Sometimes you go.
Let's hit it. I'll read it now if you want.
And something else, look it up. Oh, she's had the question.
I know.
I emailed you my writing center big paper.
Oh, did you?
At the same time? you get a bonus too, so.
I'm doing that.
I knew that was wrong, so I was like,
Thank you.
I don't know.
It's hers.
It's Chrissy.
That's why I
Thank
thought.
you. All right.
It's like Jessica
The
gave me a
rounding
quarter.
goes down to the nearest
That's,
half
that's
tablet.
the rounding
So
part
it
where.
would be either 3 or 3.5. I think it's 3.
That's what I thought I was like.
For a day, for 5 days.
Okay.
Give 0.3 cc's an hour.
You see what I'm saying, like they let you, because I tell you like round this, that's why I'm confused because it's possible.
And this is daily for 3 days.
the third, so I need 3 more.
Okay, I'll send you two, because we have one more time.
Yes.
QD is once a day. This is what.
And they're not good, because I saw one person's under me, and it's lower than mine. And she was like, here's your best friend, because she literally just scanned my hand. She's like, here's yours, and I was like, oh, well, stop. She's like, I don't know what we're gonna do about these grades. I was like, oh.
That's just, they only like put that because I'm an API when they said that.
They only have 30 questions, right?
I don't understand why.
Because it tells you on the question, it tells you like round to the nearest hundredth, or round to
That
the
means I
nearest
got
one,
20
or
hours.
round, you know, that's why.
So I missed 7.
Because it would, on these, sometimes it tells you round to the nearest.
She's grading on my
That's why I
number.
just put it.
She's grading.
because-
Yeah.
The reason I
I
didn't
walked
put
in
those
there,
in
and she
is
had
because
just
there's
seen mine, and I
standard rules for
grading,
medicine.
and then I said,
It's
pardon,
all
sir,
class.
and then I
It's
said,
just-
oh, well, that's Kathy. And she was like, I don't know what we're gonna do about this grade.
That's why I like the ones I got wrong,
Because I'm
because I'm rounding, that's why I did
And
them
it was
wrong,
lower than
because
mine.
I
Right.
refused, I was like, when,
Makes sense.
you know, everything is so different, everyone is different.
Yeah.
Mhm.
I was like, alright, cool, so it sucks.
Let me look over everybody and see what everybody did, okay?
Oh, you mean for 100 questions? I got the thing. I got like, if I missed that, that's the name. Have it, yeah.
Oh, yes.
The grading, you have to be here on the
Are you good?
Because I refuse to go to
You're
my
right,
house,
and
so,
that's 4 a day.
you know, it's all back.
You would give anyone 4 Motrin at the same time?
I'm frustrated myself because I wrote it wrong.
I don't memorize it off the top of my head.
Oh, yay. I don't know.
Remember, it's just a practice test. It's
I
not
know,
fair.
but like if it's like,
500 milliliters.
Here, we need to see here.
Yeah, she looked at it.
Oh, this thing?
Yep.
Like I said,
Is it all done?
No. People are like, can you just grab a straight line right now?
Can we take this back with us, Dr. Johnson?
What's that?
Can we take this with us, or do you?
Yeah.
No, leave it here. I got to record it.
Wait, these are grades?
What? No, I just have to know who passed and who didn't.
Still, yeah.
I had 50, no, I
You did. You had the right numbers. She needed 4 times a day for 10 days.
What do you know the reason?
One is right.
I know, right? We need to get back to class.
Can you go over this?
I'm just gonna say personally.
All right, can we go back to class? Go. We got more important things to do than a drug calculation test.
Oh, yeah.
I got all the right for one. Did you go maybe your recess? That's yours, right?
All right.
Okay.
If it's over here, it hasn't been graded yet.
She was like, you were.
I haven't graded it. No. This is right there.
No, he's
All right, go sit down. We got work to do.
Okay, you're on the one block. Go first. You're on the picture.
So, as always, our 5-minute break turned into a 15-minute break.
Because I didn't do 15.
All right. So, who has heard of NRP? Who's heard of NRP? What is NRP? Neonatal Resuscitation Program. Okay? Every single baby born in America is required to have an RN dedicated to him. Okay? And that RN must be NRP certified. Okay? If there is not an RN dedicated to the baby, they're simply not meeting the standard of care. Some hospitals have a baby nurse who is an LPN, but the RN in the room is really responsible for him. That's just wrong, okay? It's just not a very good idea. The only person in the room that's really unstable at birth is the baby. So why would you give him the nurse that has the least training? I never understood that. But they blow off the baby because, he'll be okay. And then that's where they make up so much problem. So it's ABCs, just like a newborn, the same as it is with anybody else. First thing you want to do is establish the airway, okay? A baby should be breathing or crying. A baby who's breathing or crying has a clear airway. Done. Now, the American College of Obstetricians and Gynecologists, the American Association of Family Medicine Providers, the Neonatal Resuscitation Program, they all say that if the baby requires having his airway manually cleared, you can use a bulb syringe to suction the airway. The Association of Women's Health and Neonatal Nurses, my professional organization, says the mouth and nose will be suctioned with a bulb syringe at birth. You hear the difference? One says if he needs it, go ahead and use it. The other one says absolutely use it. Okay? And when I talk about be nice to me, I'm new here, that's what I'm trying to get to, is that bulb syringes are an emergency intervention for a baby who can't breathe. A bulb syringe is not mandatory resuscitation equipment. Every single baby must have it. Does everyone know what I'm talking about when I say bulb syringe? Yeah. They're usually blue, they're humongous, and they go in the baby's nose, and they try to do brain surgery with them. Yeah, they go up the nose like this far. I'm like, what are you doing? And then they wonder why the kid's got a sore nose, the next day he can't breathe. Like, oh, he's congested. Let's put some normal saline and suck it out some more. If I took a pen and shoved it up your nose, I promise you would have a sore nose and you'd be congested the next day. It's not boogers, it's bad nose because you beat it up, okay? And I take that bulb syringe and I show it to him. And I say, can I please shove this up your nose? Would you let me shove this up your nose? The answer is absolutely not. And your nose is much bigger than a newborn's nose, so why would you shove that up a newborn's nose? If you don't like it, he don't like it either. And it's okay. He's a mouth breather. He doesn't even need his nose. Jesus Christ, fly. Golly, I must be stuck like sugar or something on me. I don't know. That fly loves me today. So you have to establish the airway and provide suction if needed. Here's an interesting little thing. 4 million babies born in America every year. And out of those 4 million babies, 3,999,999 of them end up with a bulb syringe in their bed. Okay? Now, does anyone know how many research studies have been done on newborns in the last 20 years to see whether or not bulb syringe is an effective tool?
None.
4. 4 studies covering 84 babies. 84 babies. Out of 4 million a year for 20 years. 80 million possible babies being born, and we've studied 80 of them. 1 in a million. And guess what it said on those 1 in a million babies who had bulb syringes? That they're useless. That they have no clinical value. That they do either nothing at all, or they make it harder for the baby to learn how to breathe. Isn't that interesting? Every single one, and yet we still use it. Every baby. Boy, my wife she's got 3 or 4 of them on every newborn. I'm like, yeah, they make good bath toys. I use them to squirt water at people, but they're pretty useless for a baby. But they don't help, okay?
Is that only for babies?
What's that?
Like for infants, for example, for 5 months?
No, for older babies, like when the nose is real congested and they need to breathe, that kind of stuff, yeah. But we're talking about the routine suctioning of a newborn at birth. Yeah. Now, I can't fault nurses because, like I said, our professional organization says it will happen. Okay? And if you ever watch any of the NRP videos about the things that we use to train, NRP says you take a bulb syringe, you put it in the corner of the baby's mouth, and you suck out their cheek and at the opening of the nose. Okay? Not in the nose, just the opening of the nose, right here. You don't go in the nose with it. Okay? And then if you watch a video for how to use a bulb syringe, they grab the baby by the top of the head, pull his head back, and pass it down his throat and up his nose 14 times. It's amazing. And the kid cries and they mock him for it. They're like, oh, you've had a hard day. Oh, it's so rough. I actually get angry when I watch the video. And that is the video that the American Academy of Pediatrics uses to teach neonatal resuscitation. And so when I play it on the, like I'll talk about the rules, when I'm at a conference, and then I'll say, now watch this. And I play it, and I just count. 1, 2, 3, 4, up to 14. And by the time, everyone in the audience is going, oh, because they all say, oh, I do that. They all recognize that they do the exact same thing. It's pretty interesting stuff. So suction the airway if needed. What you often hear, what I love to hear, is you'll hear a baby who has wet lungs. Has anyone heard that yet? Have they got a newborn with wet lungs? The nurse will listen to the newborn, and they'll hear wet lungs, and they'll do oral gastric suctioning. They'll pass the tube down into his stomach, suck out his stomach, and that helps clear his wet lungs. And I go, time out. If they're wet lungs, why are you suctioning his stomach? I'm not, I'm suctioning his airway. But the wet is here, isn't it? Yeah. So where is your tube going? Please tell me you're not doing bronchoscopy on a newborn with a non-sterile tube in the delivery room. Please tell me that's not what you're doing. And they're like, no, I'm just passing it down into the esophagus? Yeah, the esophagus. Whereas lungs are not? So what are you trying to get at with your oral gastric suctioning? I don't know, but it isn't the wet lungs. And they go, yeah, but it always clears. Yeah, because time will clear it whether you suck them out or not. But I promise you're not taking that tube and passing it into his alveoli and draining his lungs where the wetness is. You're not doing that at all. If you're doing anything, you're making him cry, increasing his intrathoracic pressure and pushing the fluid out of his lungs, which fine, you could do that just by smacking him in the face. He'd do the same thing. It would be more gentle than shoving a tube down his throat. Anyway, so can you tell that drives me crazy?
Yeah.
What drives me crazy, besides the fact that we think it's okay to be mean to newborns, because they can't write a complaint letter. The other thing that drives me crazy is people doing stupid things with no reason for it. I mean, are they sucking at his lungs when they suck his stomach? No. So how are they helping the wet lungs? And they've never even thought that. They were just taught, you got a baby with wet lungs, you suck him out. That clears his lungs. And they didn't even consider that it might not be true. Never even occurred to them that they were passing a tube into his stomach. That's what drives me crazy, because they have no idea what they're talking about. They don't know why they do it, and they don't know what they're doing. And that's just bad nursing. No bachelor's prepared nurse should ever fall for that trick. You got to know what you're doing. All right, so establish COA. I'm sorry, let me jump off my soapbox for a minute. Okay. Provide warmth by drying the infant to prevent what? Evaporation, right? Place him on his mother's abdomen. Why? What are you gonna prevent when you put him on his mother's abdomen? Conduction, right? You're gonna conduct because mom is nice and warm. What's really neat, you put a baby on mom's chest, her chest instantly flushes with blood, and it turns all red right here. You pick the baby up, and you'll see a big red mark on her chest where the baby used to be, because the body shifts blood right there to the baby. How cool is that? Like he's designed to be there or something, right? Give him heated blankets to prevent what? Convection, and not evaporation, radiation. The only one left, right? Or placed beneath the radiant heater, which prevents radiation as well. It just puts him in a heated environment so he can't radiate heat away. Okay? And give him a hat. Because baby's head is the largest surface area, and the theory is they lose a lot of heat through their head. Although, in the last week or two, I've seen 2 articles that talk about maybe we shouldn't be putting hats on babies. But they're not, I haven't read them, I've just seen the titles. My theory is that it makes it so mom can't kiss him when you got a hat. And that there might be something to mom's saliva on his head that might be helping somehow. I'm not sure. I have to, like I said, it's just been the last week or 2, I haven't really looked into it. Okay? You want to observe for respiratory effort. His color, you want to look at his color, you want to look at his muscle tone. A normal newborn is nice and pink and kind of drawn up like this, all right? You see him like this, that ain't happy, okay? That's not what you're looking for. You want him nice and tightened up. You want to check his heart rate, should be between 120 and 160. Check his temperature, should be 98.6. Look for obvious abnormalities. Cleft lip and palate, extra fingers, that kind of thing. If structural, obvious problems. And then check and record the number of his umbilical cord vessels. And why do we want to make sure he has 3 vessels? Kidneys, right? We want to make sure he has 2 kidneys. 3 vessels equals 2 kidneys. APGAR score. Good old Virginia APGAR. I think I mentioned Virginia APGAR once before. Anesthesiologist from the 1950s discovered that if you put mom under general anesthesia for long periods of time, it tends to kill babies. And so when babies were born, if their APGAR score was less than 5, they had a very low chance of survival, which is just mind-boggling for today. If the APGAR score is less than 8, at a minute we freak out, right? So the APGAR score, they get 0, 1, or 2 points for each of 5 things. Respiratory effort, heart rate, muscle tone, reflex irritability, and skin color. Okay, when it's really bad, they get 0. So if they're pale, they get 0. If they have a little acrocyanosis, they get 1. If they're pink throughout, they get 2. That kind of thing. Okay, and almost every baby gets 8, 9, or 9 and 9 at the 1 and 5 minute mark. Because the only problem we usually have is a little bit of pallor in the hands, and that's a 9. Okay, I have seen 2 babies out of 1,000+ births who got a 10. 2. I've seen 2. It's considered bad luck to give a baby a 10 even if they've earned it. You always give them 9 and 9. You don't want to give them a 10 even if they've earned it. It's just bad luck. So, I'm like, whatever. So this is the APGAR scoring system. Okay. So a baby who comes out with no muscle tone, no pulse, no grimace, no color in his skin, and not breathing gets a 0. Okay, that is a baby who is not with us. Okay, and then on the other side we have 2 points for each. And by the way, if you notice, appearance, pulse, grimace, activity, pulse, Grimace, appearance, respiration. That's APGAR. How convenient that she had a name that she could put that to, right? I love when that works. It's not an accident. It's in that order on purpose. Okay? And then, so you'll see this, okay? Almost every baby spends most of the time over here. And the only thing they lose points with is completely pink. This is only there, it's purely academic, medical, legal, and it's only in the first 5 minutes of life. You mark it at 1 minute, and you mark it again at 5 minutes. If they're really sick, sometimes the NICU will give them a 10-minute APGAR score, which said they were like 2, 4, and 7, or 2, 4, and 9, whatever, and that by 10 minutes they had transitioned well and they were okay. But it's almost always a 1 and 5 minute thing. First, once you've established that your baby is breathing, nice and pink, got good APGAR scores, all the life-threatening things are taken care of, you've got to jump on infant identification. Before the baby leaves his mother, definitely before baby leaves his mother's eyesight, you want to identify that that baby belongs to that mother. Okay? And we put the little bands on their wrists and ankles or on their umbilical cord, and we give mom and dad another set. And the numbers always have to match, right? Then, sometime in the first hour to 4 hours, we want to give the prophylactic medications. We give all babies eye prophylaxis. Eye prophylaxis we use is erythromycin. Why do we put erythromycin in the eyes of every newborn?
For gonorrhea.
To prevent gonorrhea, exactly. Not to prevent eye infections. I don't care if the kid gets pink eye, right? We're doing it because we think every woman has gonorrhea, and just in case, because we don't know, we're going to give them eye ointments. Okay? Not terribly needed, but okay, whatever, it doesn't bother too much. Okay? Vitamin K injection. We give vitamin K injection to prevent what? It's a coagulopathy called vitamin K deficient neonatal coagulopathy, I think. And it's, yeah, that's exactly what you were thinking. I know, it's right on the tip of your tongue, right? But but newborns, a very small number, like 1 in 50,000 newborns, will have a vitamin K deficient induced coagulopathy, and they'll hemorrhage for no good reason. We haven't quite figured out why. It's pretty rare, 1 in 50,000. But we give everybody a shot of vitamin K and it doesn't happen. And then we offer the hepatitis B vaccine. And you'll see it says consent required. It is required to give the hepatitis B vaccine. The concept is we will develop herd immunity and make hepatitis B go away if we give every newborn 3 shots of hepatitis vaccine, okay? Just like we did with smallpox, just like we did with polio, that kind of thing. We can make it this horrible disease go away. Congenital hepatitis B is a big deal. Now here's the problem. We give our hepatitis B in older children in a medicine called Recombavax. Recombavax is a combination of several immunizations, so we only have to give them 1 shot instead of giving them like 6 shots at a time. Okay, but we give the immediate newborn hepatitis B vaccine as hepatitis B. So we give him a shot of hepatitis B at birth, and then at 2 months we give him his second hepatitis B shot as a combination with other shots. So he gets that. And then at 6 months again, and then 12 months again. And what we've done is we've given him 4 doses of hepatitis B instead of 3. Okay? The one at birth is totally superfluous because it comes mixed in with their normal infant immunizations anyway. So my wife always like, no, he doesn't need 4. 3 is enough. You don't have to give it to him now. Don't poke him. You know? And she likes to be nice to babies. Why poke him for nothing? You're going to poke him anyway. The idea, though, is that they're a lot of babies get lost to follow-up and they don't complete their immunization series. So start at birth to give them at least some protection. Yeah. I say just be better parents. But, you know, what are you going to do? All right. And then assessing blood glucose. You do not assess blood glucose on every single baby. You assess for risk factors requiring blood glucose monitoring. Okay? Babies who are at risk for blood glucose difficulties should be monitored very closely. Normal babies should not. But understand that blood glucose is a big deal in newborns. And if the blood glucose is not adequately controlled, they get very sick very quickly, end up spending some time in the NICU, and could even have brain damage. So it's important. Just you don't have to do it for every single baby. You just have to look for the risk factors. And then hemoglobin hematocrit. Nobody does routine neonatal hemoglobin and hematocrit. If they do, they need to knock it off. Okay? It's an old-fashioned thing. They used to draw it on everybody, but you don't need to. If you really need to know his hemoglobin and hematocrit, get it from his umbilical cord. It's right there in the placenta. Just get it there. Okay? That's perfectly okay. And we do that that's how we tell the baby's blood type, is we get their umbilical cord blood, and that tells us what the baby's blood type is, because it's the baby's blood. Okay? It doesn't have to come from his veins. Okay? And then later neonatal assessment. We're going to check for body positioning. Again, he should have a nice good tone, right? Always like this. And what's important is that they're even. He's not doing this. All right? You see a baby doing this, it means there's something wrong with his arm. That's not an accident. They don't hang out that way. Okay? They hang out even, like this. You get one arm that's drooping, that means that we've got a brachial plexus injury or a collarbone injury or something like that. Same thing with the legs. They should be drawn up and even, not like this. Okay? So you look at him, he should be symmetrical, and he should have good tone all the way through his body. And if you can grab him and pull on him and see what his arms are going to do. Like you always see pediatricians, nurses, every time they walk in and see a baby, they grab his hands and pull his hands and kind of see what he does. Because they want to see how he reacts this way. He should react evenly. If you pull his arm and he does this, again, we got problems with that arm, right? So check his body position. What's that? It is moral reflex, I think. That's a startle. I think it's the moral reflex. But we're really not looking for moral reflex as much as we're looking for his response to our stimulation. Moral is kind of a startle reflex. You're scaring the baby and watching him do this.
Right.
Okay? His skin color should always be nice and well oxygenated, never pale, never blue, never yellow. Body size. I don't know what the heck they're talking about body size. I assume they're talking about like watching for a distended abdomen or that kind of thing. Okay? And then you do how alert are they, and then measurements of gestational age. There is this thing called the Ballard Gestational Age Maturity Rating Tool. I know it exists, and when I was going to nursing school, every baby got a Ballard score as soon as they were born. But what we learned was, are you going to treat him differently if he's 36 and 6 versus 37 and 5? No. So why do you care? Okay? Even if he's 37 and 1 versus 39 and 6, are you going to treat him differently? No. You're going to treat him differently if he acts differently. Okay? So symptoms became far more important than a Ballard score. Now, in the NICU, they can do a lot of Ballard scores in the NICU, because that means a lot. Okay? But not your normal newborn. Okay? So, when we're looking at our baby, we want to first inspect his skin, his nails, his body, his hair, looking for color, texture, looking for wounds, looking for scratches, looking for that kind of stuff, okay? Making sure that he's good. Eruptions, what kind of eruptions are we looking for? What do you think? What? When I think eruptions, only one word pops in my head, herpes, okay? So you're looking for signs of herpes. You're looking for a cluster of clear blisters on his body somewhere, okay? That means mom had it and gave it to him accidentally. Okay? You want to make sure you're in a well-lit room, and you want to look for your birth injuries. Now, this is another one of those things that drives me crazy. Pediatricians are the only healthcare providers on the planet that have the power to go, all my patients come here. I'm not going to go see you. You have to come here. Drives me nuts. You know, no cardiologist could come on the floor, attention patients, I'm going to assess you all. Please stand in the hallway and come to me. No one would ever do that. Can you imagine obstetrics? All obstetrics patients come here and I'll measure you right here in the hallway. Or we'll go in this little private room, but you have to leave your bed and come see me. No. But babies, they just, all newborns to the nursery so the magic doctor can see him in one place and not have to go from room to room. But what does that do? That means the pediatrician never interacts with the mother. Never teaches the mother about what a normal newborn looks like. Okay? Nurses have a bad habit of doing that too. They take the baby to the nursery for assessment. If you take your baby to the nursery for assessment, who can you teach? Baby doesn't care what you think, right? So you should always do your pediatric assessments in a well-lit room with the mother and father present, preferably the same place you're assessing mom. The skin should be smooth and soft. You will notice every once in a while you get these little pimples on newborns. It's like neonatal acne, these little pustular eruptions. They mean nothing. It's literally acne. It's just a newborn thing. And what I explain to people is that in the uterus He's got this perfect environment for his wonderful skin, right? But he comes out, now he's exposed to dust and to dust mites and you know, bacteria and all the stuff out in our environment, and his skin has to learn what to do about it. So they get these little skin infections a couple of times in their newborn period, and it means nothing. They're just learning how to use their skin. Okay? You want to look for, milia is the same thing, but it's on his face. And erythema toxicum, again, are those little pimples all over the baby. And little ones, just a couple. Mongolian spots. Who knows what a Mongolian spot is? There's a picture of him in your book. It's a big black spot on his butt, right? And a cafe au lait mark is literally coffee with milk. And it just looks like a light tan colored mark viewed random places on babies. They don't mean anything. They're normal adaptations.
Where's the wine spots?
What's that? Port wine spots? Yeah, there you go. So these are all things that a baby could have, and they all are normal. I love the stork bite. That is such an interesting, almost all newborns have stork bites. They're amazing. Some people keep them into adulthood. But it's a little V-shaped thing right here and right here. It literally looks like he was carried by a stork. Like a little thing you hear in here. They're crazy. My theory is that it's the baby bumping into the tailbone as he comes down. Putting his forehead right into the tailbone and getting a bruise on his tailbone. I definitely see babies who are born quickly have these big bruises right across their face where they smashed into the tailbone on the way down. Poor little guys. They'll get over it. Okay? You want to look at his head. It should be symmetrical, nice and round, not asymmetrical. Okay? Immediate newborns will often have a cone head in one direction or another. Hopefully it's just into the back a little bit. But if they were coming down crooked, that cone head could be over here or over here. But that immediate swelling or misshapen nature will go away very quickly in the first 24 hours. I love when dads always ask me, is this head supposed to be cone-headed like that? I'm like, yeah, haven't you seen all the cone-headed people walking around? Or they go, is it going to go away? No, it's going to stay that way forever. Just your baby. Everyone else is fine. His eyes should be just like your eyes. You know the newborn's eyes are almost full size. And by the age of 2, a child's eyes have achieved their full size. Which is why when you look at a preschooler, they have such enormous eyes. Okay? It's why in every anime, every cartoon, they always have the kids with the big blinking eyes. Bink, bink, bink. And you know that's on purpose. It's a survival mechanism. Because you can't ignore a baby if you've looked into his eyes. You just can't. And they got these gigantic eyes that draw your attention. We're naturally programmed to look into people's eyes when we speak to them. That's how we make eye contact, and that means, you know, I want to look at you, so I'm going to make eye contact. And so with a baby, they have these enormous eyes that you have to stare at. You can get lost in there, it's like, wow, hey eyes, what are you doing with that kid, right? And that's on purpose, because it's really hard to take him after you've looked into his eyes and throw him in the garbage. It's really hard to do. And so it's a survival technique. Okay? His ears should be nice and placed right on the side of his head. Okay? If he's got Down syndrome, they tend to have low set ears, and the line from here to here is a little bit off. Okay? Your book has a mark of it. His lips should move and be nice and pink, and his chin should be appropriate. Now, the reason those are mentioned specifically is a kid who's got a neurologic injury will have a droop in his face like that, and he'll be uneven, or he'll cry out of half of his mouth like that, and he can't. So he'll have a droop in his lips. They're not normal shape. And then there's a condition, Pierre-Robin syndrome, which has a macroagnathia, something like that, but it's a deep inset chin, makes it very hard to breathe. And so the chin should look normal on the kid. Okay? And the trick is, you know what a normal baby looks like. You look at a kid and he's kind of funny looking. You want to know, why is he funny looking? Okay? Now, if a kid is funny looking, there might be something wrong with him. So how do you know if he's a funny looking kid or if he's a normal kid who's just funny looking?
Look at the parents.
You look at the parents, exactly. Funny looking kids have funny looking parents. Okay? So if you look and you're like, oh, I see where he gets his eyes. Got it. Okay? And it's definitely true. You do not want to work up a kid for a recessed chin when you look at mom and dad and they're all like, oh. When mom and dad are dorkfish, the baby's going to be a dorkfish. Okay? That's just the way it is. They look like mom and dad.
But the appropriate answer is always, what a lovely baby.
What a lovely baby. Wow, he has your eyes. He looks just like you. Right?
Yes.
Because the sun rises and sets in the baby's face. And mom and dad look at them and they are perfect. I have seen some very ugly babies. The idea that all babies are beautiful is a lie. There are a lot of ugly babies. I see them all the time. And they always look just like mom and dad. Okay? What's really cute is every once in a while you have a baby born with extra fingers. It's called polydactyly. And they almost always, it's just a little decidual finger. There's no bones in it. It looks almost like a skin tag, but it kind of hangs off on the side over here. Every once in a while, a baby will be born, and dad or mom will immediately look at their fingers and count, and they'll look, he has your fingers, because dad was born with an extra digit that was cut off at birth. And all they do is tie a string around it and it falls off. But yeah, it's not unusual to have extra fingers. They're very common. Okay? The head, you know there are two fontanelles. Remember, we talked about them in trying to assess. There's a frontal and a posterior, right? So the frontal fontanelle, it should be a nice diamond shape, should be open and soft, and the posterior fontanelle should be smaller, triangular shape, open and soft. Okay? They should, if the baby cries, they'll bulge out a little bit while they cry just because of that increased pressure, and that's normal. But a baby who's at rest with a bulging fontanelle has an infection until proven otherwise. Okay? So we assess their fontanelle should be smooth and flat at rest. Okay? And if they're shrunken in, like you look at them and they're just like on the fontanelle, they're dehydrated, they're sick, there's something wrong with them. Okay? Caput succedanum is just the generalized edema across the scalp. Okay? And then there's cephalohematoma. All right? Caput is normal. That's just swelling on the head. But a cephalohematoma is bruising in the scalp. Okay? It usually does not cross the line. It goes right up to the edge and then it stops. Okay? And it lasts for a few weeks. And what we want to do is make sure that he doesn't have an active bleed in his brain causing that to happen. Okay? It's not unusual for newborns to have teeth. They have these little pearls in their mouth, in their gums, and they're called Epstein's pearls. And they're fine, they have no effect. A newborn should be able to suck. If you put your finger in a baby's mouth, he should automatically suck on it. And you want to make sure that he can suck and he's got a decent suck. If you put it in his mouth and he just doesn't move, there's a problem. He's got some low motor tone and he's got issues. He's going to have trouble feeding. Okay. Fascinating stuff. Just last week, I want to say it was either Friday or yesterday. I can't remember which. But the Academy of Breastfeeding Medicine met for their annual conference out in California somewhere. And a lot of the folks in the audience live tweeted the thing. And there was one researcher who blew everybody's minds. I mean, big names like Larry Noble and Allison Stubbe were in the audience, and their minds were blown by, I think his name was Mike Wallace, oddly enough. But this researcher, he did some research. Do babies suck at the breast, or do they suckle at the breast? The difference is, do they suck like you would on a straw, or is there a peristaltic motion in the breast with no vacuum? Interesting. Can you believe we're still trying to figure that out?
There's no direct pressure.
The answer is they don't suck. They suckle. They spend very little time sucking. They suck a little, but it's mostly sucklings and not sucking. Okay? Because what happens if you take a plastic straw and you put your finger on the end and you suck? What does it do? It collapses, right? And so if a baby sucks at the breast, it collapses the milk ducts inside and no milk can come out. And what happens is the milk ejection reflex pushes the milk into the tubes and dilates the tubes and allows the milk to flow. And then baby uses peristalsis to get it into his mouth. Isn't that interesting? But all these big names were going crazy on Twitter. I can't believe it. This is the most amazing thing ever. It was an aha moment for everybody. It was pretty neat stuff. Not to brag, but I knew that 10 years ago. The neck. Donna Geddes actually did research that proved that in 2007. I don't know why you guys are just making a big deal about it now, but we've always known that. Although 6 months ago, there was an article on PLOS. You guys familiar with PLOS? P-L-O-S? It's an online article or journal. They had an article, "We have solved the situation. Babies use vacuum to get milk out of the breast." I was like, wow, that's impressive. You solved it. Lifelong mystery. Nobody knows you. Nobody knows who you are. You solved the problem. Arrogant. They were wrong. Anyway, the neck should always turn back and forth. Torticollis, babies can get a little kinky, and they turn their head to the side and they stay there. If you turn a baby's head, it should flow both ways easily. Okay? He might resist you, but it's okay. You turn his head and he stays there, there might be something in his C-spine. One of the moms that we saw at our breastfeeding day, I don't remember if she came at the very end or not. Or it might have just been someone I was seeing at the same time. Her baby has like a real tight, rigid neck. And like when he sits up, he has to sit facing away from his mother to eat. And he sits like this all the time. And he's like really tight and rigid in his neck. And I convinced her to go see a doctor of osteopathy, a DO, and he did some craniosacral therapy. She did some craniosacral therapy, and now the kid who hadn't eaten in like 2 months from the breast is now breastfeeding. How cool is that? Because now he can turn his head. He couldn't do it before. He couldn't tolerate sitting at the side of at the breast and doing this stuff. He couldn't do it because he was so rigid. Yep. All right. It looks like it's 4:30. We probably have to stop. So, for the test, we will cover all the way up to slide 41 to include jaundice. Okay? Look at all this you guys don't have to test on. I was hoping to get to neonatal infections. I'm sorry. I didn't get to I didn't even get to the real.
So that's half of 18?
I tell you what, let's just make it easy. We will not do the at-risk newborn. Okay? So I'll have you responsible for chapter 18, but not chapter 19.
Okay.
Okay? Just to make it
So
easy.
14 through 18.
14, I think 14 through 18.
Basically, in the book, it's up until the assessment of the respiratory system.
So what's left in chapter 18 after respiratory system?
Well, we did do respiratory, so it's respiratory, cardiovascular, GI, GU,
Just
musculoskeletal, neuro, and then enhancing the neonatal transition to extra-uterine.
Oh, that's unfortunate.
And then discharge.
Okay. What would happen to your calendars? Whip out your calendars. What would happen to your calendars if we backed the test up by a week? What would that do to everything else? What? Would you love me or hate me? I'll give it either way.
That would put us at the same due date as our papers.
Oh, never
If you move our
mind.
paper a week, we can send it.
But then if we move our paper another week, we have exam 4 in our paper. If you push exam 3, we're supposed to have exam 4 the exact week after that.
Are we?
Yeah.
Yeah. No, it's not going to work. All right. So we'll test next week.
Is it, I thought it was 15 though.
No, we can't.
Finish the paper, I have plans for Halloween.
Me too. I'm camping.
It's part of 14.
Martin, that we're not.
It's the ones that.
So remember on the study guide, I gave a list of things not to know about. Now you need to know about
From
it.
14, right?
Yeah, from 14.
Well,
Okay.
it's not all of chapter 14, it's the
Right.
parts that we didn't cover.
Exactly.
Okay.
And so
It's the
up
parts
until
of
what
14
page
that we
on
didn't
18
cover.
did we stop? Yeah. What page
on 18?
That's tough. Let's see.
So you said up to slide 42.
Yeah, we set up to slide 42. That's where we got today, right?
Yeah.
That one.
It's 41?
Yeah, because we didn't talk anything about the respiratory system, cardiovascular system.
The assessment of the mouth is the last one we talked about.
Too bad. Just a little bit left.
No, just that slide 40. Is the very last slide.
Because he put extra slides in.
Oh, yes. Is this the same one that you posted on the that more like a few hours ago, or are you gonna repost it?
I posted it like actually last week, I
On
think.
Friday. Yeah, you only